Healthcare is changing, and Dr. Nancy RN is here for you. The topics are many, but each program stands on its own with 3 key action points for you to learn. Your guide to a healthier you in a changing world. Dr. Nancy RN.
Welcome to Dr. Nancy RN, Healthy You, Healthy Nation, Healthy World. I'm Nancy Valentine, registered nurse and PhD. And I'm going to be spending time with you, the healthcare consumer, because this show is dedicated to you. And today we have the privilege of having a conversation with a friend and colleague of mine who I'll introduce in a moment. But our topic today is a new leadership area for nurses, palliative care nursing. And Kathleen McDevitt is going to tell us about what palliative care nursing entails, what it can do for you, and what it brings to the healthcare equation for the future. So let me introduce Kathleen McDevitt, who is a very special person, very gifted in her nursing role. Kathleen started out as an oncology nurse, and then she went to the University of Pennsylvania, where she got a master's degree in advanced practice nursing in the area of oncology. Oncology means cancer nursing, cancer care. And then she was very curious, as she will tell us, about why she got involved with going on for pain and palliative care. So she got a postmaster's certificate also at the University of Pennsylvania School of Nursing. And what we really want to find out from Kathleen today is what really led her from being a very good oncology nurse in a number of different and important jobs to really moving on to pain and palliative care, and what that means, what it can do for you, how you can access these services, and what she's doing professionally to bring other nurses to the table so that they can learn about this important service that they can also offer. So Kathleen, welcome to our show. It's really a pleasure, a privilege to have you and to spend a half an hour with us today.
Thank you so much, Nancy. I appreciate the opportunity and the path that led us here.
Very nice. Well, listen, tell us about your history and how you got into nursing, what you did, what sort of really took you to that next level.
Well, I've always been very much attracted to pain and symptom management, and early on in my career I sort of developed that interest and affinity and curiosity about oncology nursing. It was a very exciting time when I entered into nursing. There were a lot of new treatment protocols that gave the opportunity to provide what I consider a more holistic approach to nursing, meaning that not only being attentive to some of the physical characteristics of caring for a patient, but also being attentive to their spirit, mind, body, and spirit. And just really learning that, understanding how the course of illness went. A big component of oncology nursing is being able to treat pain and support the treatment of pain. And that is something I did on a regular basis. In fact, I became so interested in the potentials that I had in my nursing to support pain, to relieve pain, to ameliorate the suffering associated with disease all throughout the health and illness trajectory. I decided to really specialize in the pain component. So that was my first step into pain and palliative care. But there was one pain consult in particular that changed my whole career focus, and I remember it quite well. I went in to see a patient, and several doctors had been in. In fact, 11 doctors were involved in the care of this patient, and he developed a lot of chronic pain syndrome, not just from his disease itself, but from the treatment, because there's clinical consequences of pain from treatment as well.
Can you just tell us what that is? Chronic pain?
Chronic pain. Chronic pain is pain that persists more than 6 months at a time or 3 months at a time, or acute pain that we refer to is if somebody falls or has an injury. I guess the classic example is if you were to break your leg. And we know after a period of time, 3 to 4, maybe 5 weeks, it heals. And that pain decreases each day. Or after a surgical procedure, the first 2 days, the pain may be more severe, but then it begins with the healing process to resolve itself. In chronic pain, it doesn't resolve itself, and it can maintain as being very severe, debilitating pain. It can debilitate your ability to eat, sleep, rest, appreciate, love, and enjoy the people in your family, your loved ones, your hobbies.
It becomes like the focus of your life.
It becomes the focus of your life, and you become very isolated as a result of that. And so it was very important to me to make sure the patients were as comfortable as possible. I also thought that when it came time to make decisions about treatment, they needed to be in their best state of health, even to be comfortable in the conversations, but to understand what option would best fit their capacity and goals at that time. So I went in to see this patient, And I knew in a heartbeat that I could get this pain out, this serious pain under control, because I could see that there were different options that I could use that would really help it a lot that hadn't been thought of. And I talked to the physicians about it, they were on board, and so I made those recommendations.
Can you just tell us what they were? Because, I mean, in this case, Kathleen's telling us, and this is not uncommon, that this very difficult patient had 11 consultations with 11 different physicians, all trying to get to the bottom of his disease, what was really contributing to this pain, and then the next step is how to manage it effectively. And what did you see that they were not able to see?
Well, the one thing that I saw was that he was having a lot of difficulty when he talked to me about when he went down for his radiation treatment. And he actually had some fluid in his lungs as a consequence of the disease. And that fluid accumulation, despite the fact that they tried to, manually remove it and drain it, it would reaccumulate again. And the pain was very severe, and so I recognized it as nerve pain. And physicians sometimes will refer to that as neuropathic pain, but it's nerve pain. It's like having broken wires, and the wires get disconnected and they feel pain very severely, but it sort of presents itself in different areas of the body, not always associated with the area. The injury is not always associated with the area where they're feeling the pain. It can move to different areas of the body, depending where the nerve breakdown is. But when he talked to me about when he went down for radiation therapy, that was my clue and what was happening and the struggles afterwards. And so I followed him to radiation and watched to see what happened. And suddenly I realized that when he put him in a certain position to receive his radiation treatment, that fluid in his lung, understanding the underlying pathophysiology, was pressing on his phrenic nerve. So that's the nerve in the diaphragm that goes up and down when you're breathing. So not only did he get severe pain, every breath, and he only had relief when they said, now hold your breath, and he had relief. So I knew immediately that there were that I could make recommendations about changing the position, because there was more than one way to give that treatment. It didn't have to be traditionally done in that, after speaking to the radiation oncology nurse. His breathing technique, and also how to be medicated pre and post treatment to decrease some of the inflammation in that area, so that when the fluid shifts would occur, he wouldn't have that pain experience. But the thing that struck me the most is when I went in to talk to him about these recommendations and explain who I was, he looked at me in the eyes and he looked very broken, very fearful, very tired and fatigued, and he said, "So what organ are you again?" It really caused me to pause. And I thought to myself, I know the right answer. I need to be all of the organs all the time.
So just to back up, just to clarify, he was thinking that you were going to be another perhaps physician coming in. One was for hearts, one was for lungs, one was for neurology, whatever.
Yes. He had seen someone for his lung, his heart, his kidney, his back. And with the back pain, it was a neurosurgeon, a neurologist, a pain specialist, and then there was an interventionalist, thinking about blocks. He had gone through many medications. He had been on a telemetry unit. He had a kidney specialist in. And so he just felt dismantled, like a bunch of organs laying in that bed, and he couldn't get assembled.
And also it sounds like he was discouraged.
Very discouraged. Very, very discouraged, and it was very disheartening to see that. But it really made me pause in and thought, and although I felt confident in making recommendations to help support his physicians and team to get rid of the pain, I could have walked out of that room and the pain would have been gone away, but I didn't serve and the patient didn't have all that they needed at that time. And it really struck me, and I thought there's got to be a better way to just kind of connect the dots a bit about the experience and everybody, the work that they were providing in the treatment, and to really put that patient back together again, who was utterly dismantled through the process.
So you really saw that the whole nursing contribution here was really looking at this person from a holistic perspective, taking into account that, a lot of very smart people had seen this person and had made some recommendations which you could weave together. But you were going to be the integrator, so to speak. So what happened in that case?
I'm sorry, clarify.
Well, what happened when you actually went back to help this man? When you said, okay, I got to pull all these dots together. And you sort of had that aha moment that that's really what me as a nurse can do.
Yeah. I immediately went back to his nurse. A nurse connects to a nurse. And I asked her a little bit about what her experience was with the patient, and she said, "You're hitting nails all over the head, but I just feel so frustrated. I don't know where to go. I look at a long page of medication recommendations that are available to give to me, and I'm not even sure if I'm giving the right ones. I'm not even sure if I'm saying the right things. And I think he's really afraid in there." And she had also noticed that when his physician was in there, particularly the oncologist, he was more reserved, and she felt that he was afraid to ask the questions because he was afraid of the answers, and he was afraid of what lied ahead of him. But the pain in that situation, he didn't care about participating in treatment anymore until he got relief of that pain.
Right.
He even had seen, they had a psychiatrist come in for depression because he was declining some of his treatments, and they thought he might have been depressed.
Well, he probably was depressed, but not depressed because of treatment. It was depressed because he wasn't having the most immediate problem addressed, and that was his pain.
Absolutely.
And it's very understandable that if you are focused on pain, and that has become the focus of your life, because why wouldn't it be? How can you make any rational decision about what comes next until you have this solved?
Absolutely.
So that really made an impact on you.
Yeah.
What did you do with that?
Well, the first step is I always go back to the science, and I learned in my nursing career and through my mentors such as yourself that there's an art and a science to what we do, and the art starts with the science. And so I went back to the evidence and started to research opportunities to learn more about this training, and I realized there were really big gaps, and that there were lots of educational curriculums. There was a lot of opportunities to learn in a classroom setting, but there was few preceptorships. There was few clinical preceptorships that you could have, in training in the clinical arena with these things. So I really sought out the opportunities that were there and worked hard to achieve that and pursued a postmaster's education and clinical training in that. But that really left an impression upon me because I knew part of my journey was going to empower other nurses, particularly nurses at the bedside, to be able to have this exposure to this education and clinical training.
Well, that's wonderful. Kathleen is the director of the Pain and Palliative Care program at Bryn Mawr Hospital and has done an incredible job of not only having service to the clients and to the families that are treated at Bryn Mawr, but I think she wants to tell us also about the training program that she has put together, a fellowship program for the other nurses who work at Bryn Mawr who have similar interests to Kathleen's, and they want to learn more. So she's really providing this. Tell us about your program.
Yeah, I'm very excited about it, and I refer to it as the candy in my job because I'm really impassioned, and I feel a responsibility. I've been in this field for over 28 years, and I feel onus of responsibility to give back, and I am so energized by our young nurses, and it's so exciting to see them come out of school, especially in their early years, and they have the most state-of-the-art knowledge, in their training, and they have a lot to offer.
And we can learn from them.
Absolutely. So I really embrace that with them, and I feel that it keeps me on my toes as well, too. But what I had developed is sort of a hybrid model of what I thought the experience could look like, but it was a really great opportunity because I was early in the stages of developing the palliative care program at Bryn Mawr Hospital, and I really couldn't reach all the requests that were necessary and all the follow-through that needed to occur. And since the energy was there and the motivation is there, I developed a pain and palliative care nursing fellowship in which the nurses would train with me for a period of 2 years, and so that each month we would meet, and there would be lots of didactic learning, but along with the didactic learning there would be clinical preceptorship where they would come along and learn how to do it, and some points in time evolve into doing some of the work themselves. In addition to that, what I found that was really important is that we all need to have mentors. And doing this work is not just the clinical expertise. In fact, most nurses who specialize in palliative care, the average length of experience is 12 to 15 years.
Oh, that's interesting.
Because it's important in a lot of ways to have a confidence about yourself, a life experience, and you have to have a track record and clinical experience in all disease entities. Palliative care just doesn't take care of the heart failure patient with chronic illness or the oncology patient. You have to be able to go in a critical care setting and understand how you may transition that patient. You have to talk with confidence and competence with these specialists who are going to entrust or give you the opportunity to embrace some of those recommendations. So it's really important to be able to learn that way. So that individual mentoring and those skills, and it also takes a lot of leadership. Palliative care just isn't something that pops up one day. It really takes a lot of opportunities to discuss not only with the clinical teams and physicians, but hospital leaders. And hospital leaders have different motivations in wanting these services, but the outcomes they look for are very different. How will they increase our patient satisfaction? How will they have better, durable outcomes? You know, where patients will have a more positive hospital stay, that they'll achieve their clinical outcomes, and that they won't return to the hospital more frequently because these clinical problems were not solved. And it's not just the clinical treatment plans, but do we have the support services on the outside to help transition them and give them that support? You know, all the healing does not take place in hospitals anymore. You know,
less and less.
Less and less.
There'll be more and more using hospitals for a very acute intervention, moving immediately into either an outpatient or home care setting. So the time that one spends in a hospital really has to be thinking from the moment a person comes in, how are they going to manage when they go home? But tell us a little bit more about this program. How does a nurse get into this fellowship program?
Well, they have to apply, and there's an interview involved, and it's almost like interviewing for a position, you know, and it is a commitment. It's a 2-year commitment. At the end of that commitment, they sit for certification for both pain and palliative care, so it's a pathway for that. And there's 4 basic modules in this learning, so we interview them for their potential to grow in that. The first module is to become clinical expert, and the second module is to look at education, and so they learn how to develop an educational program, objectives, do a CEU application and certificate, public speaking skills, presence. The third component or module is about quality and outcomes, so they really learn how to read reports and outcomes that way and speak articulate to those facets. And the final one is leadership. And then the leadership module is where they develop a business proposal for their evidence-based project. So basically in the evolution of this, they're building their own model, their own hybrid model within their indigenous to their clinical areas, whether it's in a critical care area, a medical surgical area, oncology area, orthopedic area, how they would develop a pain and palliative care program. They even have to develop their own mission statement, vision, and values.
That's great.
And they collaborate with their peers and physicians. And I think in the maturation of that process and to see them blossom, you know, you see the growth in this collaborative experience with physicians as well and other team members. The greatest sense of joy and pride that I've been doing it now, this will be my 4th year, and one of the members that joined our pain and palliative care team is a graduate of the fellowship program. She went on to get her nurse practitioner, passed the certification exam, and now she's working on the team. So she went from the bedside nursing in the critical care area and now is working in the pain and palliative care team doing consultations every day.
Well, that is really fantastic, because often you hear about nurses who are really not happy with their jobs or they feel like they're burned out, but programs such as this one that Kathleen has developed really keeps a nurse engaged for all the right reasons, because they're really continuing their education, but they're continuing it in a way where they are developing skills that they can use immediately. And, you know, every nurse can be a leader, and this is a leadership training program.
Yes. I believe, Nancy, I remember you coming, you know, when they have their graduation and we have a special luncheon and we bring the executive leadership. And I remember inviting you, and they were a little nervous at the time presenting that, but I think there was a lot of powerful moments in that room to hear the evolution of that growth, and some tears as well too, and people really fulfill their dreams and their passion. That's what that's about, and to be able to mentor people and to, you know, stimulate them in their learning and their curiosity and to fulfill them that way and to validate them. The projects were amazing. I mean, one of our early fellows worked with the parish nurses in the spiritual community to develop a bereavement support group for the first year for patients who have lost a spouse. We had one nurse in particular who was really struck about the experience that she had personally in taking care of her mother at end of life, and she was the mother of 5 children. And so she and her children wrote a children's book, and she developed a bereavement kit and collaborated with our hospice program, developing a whole bereavement kit and program for patients in the hospitals, because, you know, little children don't hurt the same way. So, and it's very important, and a very common question that we have when we're talking to patients and families. Grandparents are concerned about their grandchildren just like they're concerned about their spouses and their children and how to talk to them and prepare for them. So, and they can spend a little bit of time in the hospital. It can be frightening. It's a great way to educate them as well.
Right. Well, I think that, again, a lot of times people don't realize what nursing really brings to the table as part of the team. And really, our leaders are really making the difference in clinical care. I mean, we have so much emphasis on physicians, and we need to, because there are many wonderful physicians, and they have a very special role. But nursing is evolving, and I think what you're hearing from Kathleen is a very striking example of how that evolution really has a trickle-down effect, because most of the nurses that she's talking about are bedside nurses. They are the ones that you're going to see, or your family's going to see, or your relatives, or your neighbors. They are the ones that really can make the difference. And I think that the skills that you're telling me that they come out with from this program is an understanding of not only what palliative and pain management is, but how to actually provide those services. So even though Kathleen is heading up a team that moves throughout the hospital that really helps on these complex cases, the nurses at the bedside can really move in and do that kind of work, that service, that discussion, helping patients connect their own dots, giving them hope, giving them more pain relief, etc., really early on before a team maybe even gets involved.
Right, and it is. And to bring that at the bedside level is just phenomenal, because we have to invest in that so much so. And I really feel that just even if they don't go on into fulfill the specialty of pain and palliative care beyond their experience at Bryn Mawr Hospital, because I see them with very long and tenured careers, those principles will carry them, and it generates more enthusiasm. And as a result of it, I mean, when nurses in the midst of their career, 52-year-old women say, I'm going back to school to get my master's degree or my doctoral degree, that is just so thrilling. It's just so thrilling.
But for our audience, you know, Bryn Mawr Hospital, one of the mainline health hospitals, is a magnet hospital. And part of being a magnet hospital is to have this kind of inquiry, to really build programs, to have research, to really have cutting-edge programs that give the best outcomes. So I think that part of the overarching framework here is that nurses in magnet hospitals like Bryn Mawr are always searching for what's the next best thing. What can we do to improve care? What can we do to improve the services that we are delivering? Now, in terms of the current nurses that are in school for programs, so they're training to become basically basic nurses, either an associate degree, a diploma, or a baccalaureate degree. Do you see them having more exposure to this kind of subject matter in their programs? And if so, how do they hear about it?
Absolutely. I think what we see so many times when we do surveys and our training orientation of new nurses, as we socialize and indoctrinate them in their clinical acquisition into the healthcare arena, on the top 10 list, if there's a David Letterman top 10 list, number one at that list is the fear of taking care of somebody at end of life or dealing with pain. And the psychomotor skills of maybe putting a line in or mastering that skill fall further along, and that's a little easier to achieve, but there's a sense of fear and awkwardness. There's also a great potential to have some compassion fatigue or moral distress in chronically taking care of these patients when we don't have the tools or understanding or feel empowered to do that or ask for more for these patients.
All right, I'm going to stop Kathleen right there. You used two big words that the average person, including a lot of other people that may even be professionals, will not know the definition of compassion fatigue. Let's start with that one.
Compassion fatigue, that's been a term that associated many years ago when I first started my career. They talked about burnout, and I used to think, wow, you have to be on fire and wish to have been burnt out. Some of these people that burn out didn't quite look like they were ever on fire, so I wasn't sure if that was the right answer. But quite frankly, seeing patients witnessing suffering over and over again, it really comes from the evolution of what we understand as post-traumatic stress disorder, and it was observed a lot in the military. And when you witness death or suffering or trauma over and over again, that this fatigue comes upon you. And I think with nurses, because it's a very intimate relationship, you know, if you do something, even if it's in the best interest of the patient and it hurts them, like putting in an IV or giving them a needle, you know that relief is going to come. But if you start to witness death or patients having very difficult pain and they're in a lot of distress or distress in breathing and you're not able to relieve that, it's very traumatizing for you. And why this is a problem is that over time you start to protect yourself by withdrawing for the patient, not being as emotionally available, and you're not able to give them the compassion that they deserve, and you're not able to experience your own compassion. So we refer to it as compassion fatigue.
Right. Okay, and then the second big word that you used was moral distress, and this is in relation to young nurses or middle-aged people that are going to nursing for their second career, and things that get in the way of really, again, learning their skill base to the best of their potential. So tell us about the moral distress component.
Moral distress is anytime, there's a lot of conflict, and sort of it can be the conflict in their confidence in to be able to take care of a patient, feel competent in taking care of the patient, and it can also be when they don't feel empowered to really verbalize what they're saying, and because they feel, well, that's the doctor's role, or they're not asking me for these questions, but they're saying something there. And so when there's a conflict about that, or if they try to discuss something and those doors are closed, and it's challenging in a healthcare environment, especially for a new nurse who's trying to hone their skills of being a critical thinker and just time management. So you want to do these things, you want to practice in that way, but you also have competing demands. But I also have to, fill out my paperwork, I have to do this checklist, I have to make sure that, my patients get down to physical therapy or a test, and it can be very, very difficult. And so with the patients who are more severe and chronically ill, it can feel very much overwhelming, because this healing process just doesn't happen. Well, the next day they're better, the next day better. What if each day they're worse, or what if they were good during the day, but they're really not good at nighttime? And there are not a lot of, notoriously, there's a lot more people available, and traditionally, during the day in a hospital setting than there is in the evening or weekends.
Right. So I think that what Kathleen's saying is that in order to help people learn and master their just basic nursing skills, schools are paying attention to this, and they're teaching more about pain and palliative care, because they know that if the students have that knowledge base, that will help them to be better and more successful in their nursing career overall.
Yeah, it's about that presence. I go down the hallways, and as soon as you see the students there, and the instructor will be, "Oh, Kathleen, I know you're busy, but could you talk to us?" And it starts with post-conference. We're talking about a case or an involvement, and now it's pretty routine. At Villanova University, which is down the street from Bryn Mawr Hospital, I do a special lecture for the senior students every year. So, and that's been very successful.
I'm sure. What do you think is the future for palliative care nursing, especially you as an advanced practice nurse, which is a leader among leaders? Where do you see this specialty area going?
I think it's what I've experienced at Bryn Mawr Hospital. I think it's our past is what prologues our future, and I think that's where the future of palliative care nursing is. I think you're going to take it from the bedside to the boardroom. I find myself more being called in the forum for vision and strategic planning on how to develop these programs and the standards of the programs. And even though we have medical leadership, and I practice in a very collaborative model with Dr. Carr Allsweed as medical director, I'm really asked to develop the program. And I think it's a lot of the skills that we have as nurses. We don't realize those skills. My early training in nursing as a clinical nurse specialist, I think, best prepared me. You were trained to be the consultant, the leader, the expert practitioner, the change agent. And they all sort of blend together. And so you don't lose those skills. You may focus them in a different way, but I really feel that we're more into program development and looking at standards that way. Also drawn into quality forums, and patient outcomes, patient satisfaction. This is not something or themes that we talked about 15 years ago. We wanted our patients to be satisfied, but we weren't leaders in defining those practices and systems and processes to support that.
Well, I think we've learned a lot from Kathleen today. As you can see, it's a really rich and varied field. So there's a lot of information out there about pain and palliative care, which we can access in very different ways. But I think what we've really also experienced from Kathleen is her unique passion and dedication to this. It takes a very special person to do this kind of work, and I think Kathleen is an exemplar. Anyone that would go into this particular field has to really have that kind of passion and dedication. But I love the fact that you're really sowing the seeds with the other nurses, whether they're younger, mid-career, or even beyond mid-career, that they have really caught the wave of this passion, that they are taking the time and the attention to learn. And I also think it's a tremendous compliment to the leadership of Bryn Mawr Hospital, because they are supporting all this training. They are giving nurses time away from the bedside, because they also recognize the value that this really brings to the clients that they serve. So again, I want to thank you for your time, for your
Thank you.
talent, for your energy, Kathleen. And maybe we can have Kathleen come back and give us some more understanding of what her daily routine is, because I think she puts in a tough day. Thank you. Thank you very much for being with us today. I hope you enjoyed our conversation today and that the information will help you in meeting your health goals. Catch this program and other conversations on the website, drnancyrn.com. Or you can write to me as well. I welcome your comments and feedback. Thank you for listening, and join us again. And remember, with health, all things are possible.